Schizophrenia is a serious disorder that affects millions of people worldwide every year. It's also very misunderstood by the general public. So in this lecture, we'll discuss not only schizophrenia, but the impact of psychological disorders in general. We'll talk about the stigma that is often and unfortunately attached to disorders, as well as some of the many misconceptions about psychological disorders. Firstly, the term schizophrenia is used to describe a group of disorders that share certain characteristics. This includes breakdown of personality functioning, withdrawal from reality, distorted emotions, and disturbed thoughts. And historically, the term schizophrenia was used as a catch-all phrase for any number of disorders. Today, the definition has been tightened to provide better diagnosis and better treatments. So, in order to provide an accurate diagnosis and therefore appropriate treatment, the DSM really narrows down the definition of schizophrenia by ruling out any organic or affective causes. So we know that one of the symptoms of schizophrenia is auditory hallucinations. And this could be anything from voices to just whistling noises. So what we need to do is establish these perceptions do not have an organic cause in the inner ear, the ciliary or the basilar membrane, for example. We would also need to be sure that the symptoms, such as flat affect or lack of motivation, are not caused by affective disorders such as major depression. And again, doing so allows for a more specific diagnosis and therefore better treatment. This is especially needed in schizophrenia, as the drug treatments can have strong side effects. When we talk about the effects or symptoms of schizophrenia, we talk about positive and negative symptoms. And this is not to say good and bad, but rather positive as in additive, meaning the symptoms were not present before onset, but now they are. And these include things like delusions, which would be false beliefs, hallucinations, whether it's auditory or visual, severely disorganized thought processes, speech and behavior, and then motor activity, odd movements and gestures. Negative symptoms refer to losses or things that were present before onset and now are gone or reduced. So we have a flat affect, showing very little emotion on the face. An inability to feel pleasure, lack of motivation, or lack of meaningful speech, and cessation of personal hygiene. There are several types of schizophrenia, each with its own specific symptoms. Paranoid schizophrenia involves strongly held delusions of either persecution or grandeur. The onset of these symptoms tends to occur later in life, in the 30s, than in other types of schizophrenia where we see an earlier onset. In this case, individual rarely displays disorganized behavior. Outwardly, they seem perfectly normal. Their behavior is perfectly normal, but they may eventually or at times act upon these delusions. And this results in behavior that seems unreasonable but to observers, but is perfectly reasonable to the individual themselves. And so, just to clarify, delusions are irrational thoughts or beliefs. Hallucinations are sensory experiences that have no physiological cause. Both delusions and hallucinations can be present in paranoid-type schizophrenia. In disorganized schizophrenia, we see inappropriate behavior and affect, including odd movements, disconnected emotional states. It also involves incoherent language, what we sometimes call word salad, where words and ideas just jump around, they have little coherence, the person just, day window, gone to the sheet before ball Tuesday. In catatonic schizophrenia, this is probably the most obvious or most apparent type of schizophrenia. In this case, we see either frozen or rigid limbs or excitable, purposeless motor movement. And this can mean that the person is frozen with their arms above their head for hours at a time or in a particular position. We can get what we call wax-like movement, where the person is frozen, but if you move their arm, it will stay in one position until you move it another way, and then it stays in that position. Or we can see just a complete loss of purposeful movement. We can also get what's called echolalia, which is continuing repetition of recently heard words, or echopraxia, which is the repetition or mimicry of another person's movements. So catatonic schizophrenia is very obvious to see, and of course very debilitating. We also have undifferentiated schizophrenia, where we see a mixture of many different symptoms from different types of schizophrenia. So when it comes to how schizophrenia occurs, we see two varieties overall. Typically, we see the disorder occurring younger in men, about 25 years old, and in women between 25 and 45, although it can occur earlier than this. It affects men and women equally in equal numbers, and occurs in about 1% of the total world's population. Interestingly, schizophrenia, along with depression, are the only two disorders that occur in all cultures around the world. So the first type of onset for schizophrenia is what's called gradual onset. So we'll start to see some changes in personality early on, sort of social withdrawal, and then what we call the premodal phase, sort of an increasing withdrawal from society, from social interactions, along with some peculiar actions and peculiar language. And then we go into the active phase. This is full-blown symptoms of schizophrenia, along the hallucinations, delusions, movement, what have you, that may then or will subside after time, and the residual phase, where the symptoms are no longer apparent, but there may be some remaining impairment of functioning. Generally speaking, about 1/3 of patients recover from a schizophrenic episode. 1/3 are helped with medication, but retain some symptoms, and 1/3 are not helped at all by any type of known drug therapy. And so this is often referred to as the rule of thirds. Or instead of a gradual onset, we can have sudden onset. The person is symptom-free, and there's a sudden schizophrenic episode. This tends to occur earlier in life than gradual onset, in early 20s or late teens, and presents a better prognosis for recovery with no reoccurrence. So this may happen one time and then it's gone, and we don't see it again. Whereas with gradual onset, we tend to see an increased rate of reoccurrence later in life. Interestingly, the long-term outcome, or long-term outcome studies, I should say, regarding schizophrenia have shown that recovery is more rapid in developing countries than it is in the United States, Europe, or Russia. This might be due to a sort of greater acceptance of the disorder and better work opportunities that are available in third world countries for people who are suffering from or have suffered from schizophrenia. And this has some implications for social policy. For one thing, in developing countries, we may see less stigma attached to schizophrenia after the symptoms cease. Whereas in developed countries, like the United States and Europe, the label schizophrenic still remains even after the disorder has been treated and has long since gone away. And this, of course, is going to impact the rate of recovery for the individual. Explaining the causes of schizophrenia is very difficult. Certainly there's a biological component. Again, studies in family studies, twin studies, adoption studies have shown that there are strong genetic factors that schizophrenia does run in families. We can see abnormal brain chemistry. Perhaps some studies have shown that the neurotransmitter dopamine plays a role. For certain, we see that dopamine blocking drugs reduce the symptoms of schizophrenia, particularly the positive symptoms. So we can see a biological component. In some patients, there's evidence of a prenatal viral infection that may be the basis for the cause of the disorder. Abnormal brain structures have been shown to play a role, particularly the frontal lobes, the temporal lobe, and the basal ganglia. And the ventricles of the brain, the fluid-filled ventricles, are often enlarged in patients with schizophrenia. The question remains as to whether these brain abnormalities cause the disorder or are they a result of the disorder. And this strong biological component may explain why we see schizophrenia in so many cultures all around the world, that it does seem to be biologically driven in some way. Keeping that in mind, then, schizophrenia can be viewed as a very complex sort of chronic medical illness, similar to diabetes or perhaps cancer, that affect different people in different ways. Nobody has yet nailed down or been able to really identify a single psychological factor that's a consistent cause of schizophrenia. So the genetic predisposition seems to be the strongest indicator right now. And those that have this genetic predisposition then would be more vulnerable to factors, anxiety-inducing situations that can trigger an occurrence of the schizophrenia. Okay, so we really have to discuss the overall impact of psychological disorders. First and foremost, we have to acknowledge sort of the level of occurrence. The World Health Organization estimates about 400 million people worldwide suffer from psychological disorders. And while not all disorders are seen in all cultures, there is no culture in the world that is completely free of psychological disorders, particularly depression and schizophrenia. In the United States alone, it's estimated that 15% of the population are in need of psychological therapy. We know that almost 2 million people per year are admitted to mental hospitals or psychiatric units. 2.5 million seek outpatient care. And in any given year, 5 million adults and 3 million children suffer from acute episodes of one of the 5 major disorders. So schizophrenia, bipolar, major depression, obsessive-compulsive disorder, and panic disorder. So this is obviously a huge number, and many people go without treatment due to a lack of health care. We also have to discuss the stigma that unfortunately goes along with a diagnosis. And this is based on a number of misconceptions. First and foremost is the assumption of fault, that the person suffering from the disorder has something intrinsically wrong with them. And this is distinctly different from how we see other afflictions, such as cancer. When we know somebody has cancer, we may ask, what's wrong, as opposed to what's wrong with that person. And this is an important distinction. And this is one of the misconceptions, that one of the aspects of the stigma that we need to work to overcome. And other misconceptions include this idea that people with mental illness will never recover. And that's simply not true. We have a 60% success rate in treating schizophrenia, 65% for bipolar. Major depression is treatable 80% of the time. And so many mental illnesses today can be diagnosed and treated as precisely and as effectively as any other medical disorder. And also, this idea that all people with mental illnesses are a danger to society. Again, that's simply not true. People with mental illnesses pose no more of a crime threat than do other members of the general population. And statistically speaking, they're more commonly victims of crime than perpetrators of crime. Another misconception is that people who have been treated for psychological disorders will make poor employees, and they find it very difficult to find jobs because of this misconception. And again, it's not true. Many studies have shown that those with disorders are as good at any given job as any other employee. And there are many employers who show or report that those employees are more punctual, have a better attendance record than their co-workers. Luckily, there are a number of organizations that are working to combat these misconceptions. of course, the American Psychological Association, the National Mental Health Association, and many others that are working hard to educate the public about these misconceptions. Some of the goals of these organizations are, of course, to educate, to confront the discrimination that occurs in healthcare services, in insurance coverage, in access to housing, to education, to employment, challenging the negative stereotypes that are portrayed in the media, particularly in today's world where we're seeing so much violence in the media or violence in culture that is often in the media paired up with a mental disorder, and that creates a very negative stereotype. The organizations are also working to show that treatments work, that therapy does work, and that people can recover and lead full, constructive lives. And ultimately to achieve an understanding that there is no fault in mental illness, that it is a biologically brain-based disease and should receive the same attention and concern and the same amount of money for research as do other physiological or physical diseases. So there's still a lot of work to be done in this area. Recently the focus has moved towards ensuring adequate access to services, particularly healthcare. So this concludes our discussion on disorders. Our next unit will be on treatment and therapy.